what we can give. So, as an antioxidase inhibitor like rofecoxistat or allopurinol, and then the dictum is always start at a low dose and up titrate slowly to avoid any triggering initiation of inflammation or because of the initiation of your ULTs. And then next, we have to target to control the sulfuric acid so that gout will not happen again. It will be controlled and ensure patients' compliance with your urate lowering therapy. Next. So all of these are guidelines taken from the American College of Rheumatology. So for patients with one or more subcutaneous tophi, so once nakita ninyo masisa lang sa ear or anywhere, it is strongly recommended to initiate a urate lowering therapy or ULTs. For patients with radiographic damage due to gout, we should give. For patients with frequent flares, more than or equal to 2 per year, it is strongly recommended to start your ULTs. For patients who have previously experienced more than one flare but having frequent flares in the past 2 years, it is recommended to start ULT over to low urate lowering therapy. So it is important, aside from the history, you ask how many times have you had this knee joint pain? For example, we're just in February. For this year, how many times naman? Dr. January Catalogue. So that's significant information. For 2025, more than 2 ba or 5 so that will be already time we should give. Next. For patients experiencing the first flare, we conditionally recommend against initiating ULT over no ULT. So for first flare, which is very seldom. So first time for the last, kita nilang dito. You, of course, we control the inflammation and then probably after the base control, you get your sulfuric acid. You check kung saan comorbidities sa patients, what are his medications, family history. Do not jump right away. So first, you should just give medicines or do corticoids and then the inflammation and pain first. But there are exceptions to this. For those patients experiencing the first flare and it has a CKD stage 3 or above, with a serum uric acid of more than 9, or the presence of uronithiasis and shaking stone. So definitely we should give this patient ULTs. And this is also very common for patients with asymptomatic hyperuricemia, those with more than 6.8 serum uric acid levels, with no prior gout flares, no tophi. It is conditionally recommended against initiating any pharmacologic ULT, so allopurinol or rofecoxistat, over initiation of pharmacologic ULT. So usually, with asymptomatic hyperuricemia, it is said that only 20% with a serum uric acid of more than 9 in the next 5 years would experience their first or gout flare. So the 80% actually do not have. So it is not recommended to give right away, especially in elderly patients. So probably control first and comorbidities or any other modifiable conditions of this patient. Next, for patients starting any ULT, it is strongly recommended allopurinol over all other ULT as preferred first-line agents for all patients, including those with CKD stage 3 and above. So with this, I know there are some concerns because allopurinol may have hypersensitivity reactions to some patients, but with allopurinol, it is cheap, it is well documented through literature, and it has a very long track record already for addressing hyperuricemia. For allopurinol and febuxostat, it is strongly recommended to start at a low dose, with subsequent dose titration over starting at a higher dose. So start low, probably in the next 2 to 3 weeks, and then gradually up titrate. Next. It is strongly recommended to initiate or prophylaxis therapy like colchicine, NSAIDs, and prednisone, and then it is strongly recommended to continue anti-inflammatory prophylaxis for the next 3 to 6 months, rather than less than 3 months with ongoing evaluation, and continue prophylaxis as needed if the patients continue to experience fear. So, among these three, the colchicine, NSAID, and prednisone, it's safer to give colchicine, and we do not just give colchicine because the patient is in pain. We continue to take for the next 3 to 6 months, depending on how we evaluate how disciplined is already the patient in controlling his hyperuricemia so that he will no longer have these flares. So the good thing about colchicine is an anti-inflammatory prophylaxis. Maski normal na serum uric acid, we continue it even for just 1 tab a day. Next. So for patients taking ULT, it is strongly recommended continuing this to achieve and maintain serum uric levels, the target of less than 6, especially for those with gout, experiencing gout, and then those with tau-5 to less than 5. We continue it in the future when the patient already is in remission. So, patient with no tau-5 flare. So, for example, is already in remission. It is said that only 30% of patients with less than 7 serum uric acid levels will have no flares in the next 5 years. So it is better, hopefully, it won't be that burdensome to the patient to give and continue your ULT. Next. So for lifestyle modification, this is very important, dietary changes. Reduce protein intake, limit or better avoid alcohol, limit high fructose containing food. So not all very rich food convey an equivalent risk to trigger gout. So seafoods like shells, shrimps, crabs, and lobsters. A good one, everybody has a favorite go-to seafood. So be careful. For red meat, there's pork, beef, lamb, goat, turkey, and pure tuna. Particularly organ meats like your gizzard, animal intestine, and liver, they convey increased risk for hyperuricemia and complete flares. Puree-rich leafy green vegetables does not convey such risk. Basta parang plant-based puree-rich food. So when your patient said, don't be only cow, goose, or lumpia, cow, but then again, the patient saying, kung paano daw kayo sakit yun after 1 to 2 days. Ito na. Iyan ang kanilang experience naman nila. But if the patient has he or she needed so, maintain adequate hydration and healthy weight. Next. So this one, these are the fruits here, which shows us which one has a high fructose fruit and low fructose alternatives. Unfortunately, I cannot see the durian. But then, half cup lang foods. Urine foods, so there goes, you can see the high, the moderate, and the urine-free. Next. Okay, this is an example of a Filipino breakfast. Another common question, daw okay ba mag-oatmeal? Yes, pwede. Coffee daw? Yes, pwede. Do not put na sugar. Pwede low-carb meal. Morning snack, a small apple, little almonds, unlimited water. Hopefully it's not, it's okay. And then lunch, rice is 1 cup lang. Regardless of brown, red, or white, 1 cup lang. Chicken, palm size, pinakbet, ampalaya, unsweetened caramel juice, water, no sugar. Afternoon snack, you can have yogurt as long as it's not flavored, sweetened, boiled saba. Dinner, 3/4 a cup of rice, tokwa, tilapia, and fried, steamed, and again, water. So in summary, gout is an inflammatory arthritis associated with hyperuricemia and deposition of your sodium urate crystals. Its diagnosis is based in history of joint swelling and pain, resolves in 1 to 2 weeks. Then there is also profile, aspiration, joint aspiration showing your energy crystals is the gold standard diagnosis. And then typical radiologic findings in the X-ray. So acute flare management, you give NSAID, colchicine, or corticosteroid. Long-term management, initiation of your ULTs. Lifestyle modification is also very important. And then maintain a healthy weight and adequate hydration. It is very important to remind our patient kasi kung sa kamahalon or dito tambal, even if you are religiously taking it, but there's no adjustment, there's no discipline on his part regarding the modifiable stuff in your lifestyle, go beyond the flare. So this is my last slide. Next. These are my reference and thank you for listening.
Thank you very much for the very informative lecture and our window. So the floor is now open for questions. So we will invite at least 1 or 2 questions to address the floor.
It is recommended to 3 to 6 months. Even asymptomatic. Ako second or third, the patient flare, then you start go back to the...
Yes, Doc. The last flare will be your starting point.
Yes. Now, one time, during the conversation with friends and relatives, when consult, then down. So I said, okay, I did this, and then steroid, colchicine 3 times a day, and I said, for at least 6 months. I have a relative, orthopedic, practicing in Cebu. He was surprised to see, 6 months? Yes, that's what the rheumatologists say and what the recommendations give. So 6 months, 3 to 6 months, until when the patient is asymptomatic now. On the 4th or 5th month of flare, back to 0. So now, okay, that's not what we practice. It's just a problem.
I cannot say, but by the guidelines from our books, this is what should be done. So sometimes, yes, Doc, I've seen some they can only give you short course colchicine, sometimes multiple tablets in a day. Advice lang na if they have MPM or water schools to decrease or even stop. But hindi tayo ang prophylactic at inflammatory sa colchicine. And syempre, well, you could give that to NSAIDs too, pero kasi gusto ko ito na nephrologist. So, I still give colchicine. So, it's just not tiny problem. Thank you, Dr.
Hi, good morning. Is there some level of uric acid where you can say that you're not going to want to flare?
Actually, no go. Kasi as what nature center, we continue